The criteria for performing a needle cricothyroidotomy is for those patients as part of a stepwise airway approach where we are unable to ventilate or oxygenate due to a complete or a near complete airway obstruction. These patients are dying because of an airway problem. The signs and symptoms of acute airway obstruction include an increased respiratory rate, cyanosis, a reduced level of consciousness, stridor, the use of accessory muscles, or unconsciousness or cardiac arrest. The complications of performing a needle cricothyroidotomy are damaging the underlying structures, and the most important thing for us to do is to remember to insert our needle in a central position to try and avoid hitting those other structures. Within this emergency procedure, I'm going to quickly decontaminate my hands. And pop my gloves on. The patient will be positioned supine with their head slightly extended to expose those structures underneath. When we think of the anatomy of the upper neck, we've got our thyroid cartilage here, which is our very prominent cartilage, our Adam's apple, and underneath of it we've got our one single complete ring of cartilage, our cricoid cartilage. Sitting between the two of these cartilages is our cricothyroid membrane. So with my patient's head in that slightly extended position, I can feel centrally up the trachea for the firm cartilage, where I have a complete ring of cricoid cartilage, a soft membranous area, and my thyroid cartilage above it. I'm going to prepare my cannula. I've got a 14 gauge cannula here. I've got a 10 ml syringe. And I'm going to remove the white cap and also the lure lock from the back of the cannula. Then the syringe can fit nicely on the end. Re-identifying that site of the cricothyroid membrane, I'm going to expose my sharp and insert it into the cricothyroid membrane at a 90-degree angle to the skin until I feel a pop. I'm then going to aspirate, and hopefully if I'm in the trachea I will aspirate some air here. I'm then going to realign my cannula with the trachea, lowering it down to a 45-degree angle. I'm then going to advance the cannula, removing the needle at the same time and disposing of the sharp straight into the sharp spin. We need some oxygen tubing. One end will go into the oxygen cylinder itself, and the other end will go onto one of the ports of a three-way tap. With our three-way tap, we want to ensure that each direction is open. So I'm going to make sure that we have airflow in each direction, both from the oxygen coming out to the spare port and also going into the cannula. So I can now attach this onto the end of the cannula. And turn my oxygen on. This procedure is called transtracheal jet insufflation. It provides oxygenation to the patient, but it does not ventilate the patient. So for an adult patient, I'm going to direct 15 litres of oxygen into my tubing. And I'm going to put my finger over the open port of the three-way tap, thus directing oxygen into the patient's lungs for 1 second, and then remove it for 4 seconds. On for 1, off for 1, 2, 3, 4. On for 1, off for 1, 2, 3, 4. If I had a child, I would ensure to direct the number of litres of oxygen as per the age of that child. So a 7-year-old would get 7 litres of oxygen, an 8-year-old would get 8 litres of oxygen, so on and so forth. And I would have half a second on the oxygen and 2 seconds off.